Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Providing Behavioral Health Care During the COVID-19 Pandemic, Social Workers' Rapid Transition to Tele-Behavioral Health. And it was presented on May 20th by Brianna Lombardi, along with special guest moderator Sue Skillman. Now, with that said, I'm going to go ahead and turn the event over to our guest moderator, Sue Skillman. Sue is from the University of Washington's Center for Health Workforce Studies. Sue?
Thanks, David. And yeah, I'm the Senior Deputy Director at the Center for Health Workforce Studies at the University of Washington. And I'm really pleased to be able to take on this role today and hear this presentation. As I'm sure most of our audience is aware, the rapid rise in the use of telehealth during the pandemic clearly increased access to health services when clinics were closed or when patients were not comfortable seeking in-person care. So now we're all asking questions about how well that worked. When and where should telehealth be continued? Where should it be increased or reduced? What do providers think about using telehealth? And how has it been received by patients and clients? So to address some of those questions, I'm very pleased to be able to introduce our speaker today, Brianna Lombardi, who will be sharing her team's recent research examining social workers' transition to telebehavioral health during the COVID-19 pandemic. A bit of background on Brianna. She's an assistant professor in the School of Social Work at the University of Pittsburgh, and she received her master's in social work at the University of Pittsburgh and her PhD in social work from the University of North Carolina at Chapel Hill. She's also an expert in social worker roles in integrated healthcare and has conducted research in the areas of health and behavioral health workforce and behavioral health integration in primary care. She currently receives funding from HRSA, including through support from the Behavioral Health Workforce Research Center at the University of Michigan. So Brianna, over to you.
Thank you so much. And thank you all for joining us. I'm so curious to hear your thoughts and your feedback. As Sue mentioned, I am a professor in a school of social work. And really this study, came about because I was hearing my students doing the field placements and certainly social workers in the field really describing how overnight they changed their practice to provide care. And you'll hear a little bit more about what influenced their change, the rapid change in care. But certainly we thought this could be a time where we could learn from this rapid transition and think about ways that this could move us forward for future telebehavioral health. And I just wanted to highlight my collaborators, Dr. Lisa Zerden at UNC Chapel Hill School of Social Work and Christopher Thyberg, who's at the University of Pittsburgh School of Social Work. This project was funded by the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health. And we also wanted to thank the National Association of Social Workers, or NASW. They helped distribute this survey to their membership. So just to kind of bring us back, although many of us probably don't want to be brought back to March of 2020. But really this was, a unique moment in time. As of April 1st, 2020, 95% of Americans were under stay-at-home orders due to COVID-19. And really this created how are folks getting the care that they need? On March 6th, President Trump signed an emergency funding bill that expanded telehealth coverage, but certainly it was the March 17th in kind of expansion that allowed for telehealth, particularly for mental health counseling, to be approved. And then that was at the same time where there was some relaxation on HIPAA policies for televideo care. And then again on April 30th, another important provision was that telephone or audio only telephone services were being covered by Medicare. And we know many state Medicaid followed suit, or all state Medicaids followed suit, but then also many governors enacted policies to support private insurers to provide care through tele-behavioral health. This is just kind of a quick graphic to see this kind of, overnight transition. This bottom line is televisits. This is for ambulatory type visits. Prior to the pandemic, as compared to in-person visits, and just kind of overnight this kind of rapid switch. And we do know there was some regional differences in kind of this transition. We also know that the need for behavioral health care never, never lowered during this time. Certainly, many are estimating that it actually increased. This is from the Kaiser Family Foundation, which really described that in particularly for folks who were essential workers, rates for anxiety and depressive disorders increased, rates for substance misuse and stress increased, and even rates of suicide and consideration of suicide increased. For those who are a little unfamiliar to social work, obviously social work is one of the largest behavioral health providers in the United States. And although there is significant evidence that has supported telebehavioral health, social work as a field has lagged behind its peers in training the social work profession and using telebehavioral health. And certainly a lot of that has been constrained to thinking about kind of the ethical limitations of providing telebehavioral health. But beyond social work and into the larger behavioral health context, we knew these barriers to delivering telebehavioral health existed prior. Obviously there was limitations in billing and reimbursement, limitations in provider training and education, limitations in the organizational implementation. So do large organizations have the technology and capability to provide, to have their providers use telehealth? And then certainly some concerns regarding financial barriers for clients as well into using telebehavioral health. So even prior to COVID-19, the initiative to telebehavioral health was moving, but certainly the billing and reimbursement was the largest barrier to it being more widely used. But again, COVID kind of washed all that away, and overnight really due to kind of the emergency status allowed for both reimbursement and parity for billing for telebehavioral health. So we were really curious about kind of capturing this picture in this moment of time. So understanding the extent to which social workers as behavioral health providers transition to telebehavioral health, we were interested in understanding the barriers and facilitators to them using telebehavioral health during COVID-19. And we were also really curious if this moment in time could spur long-term adoption of telebehavioral health in terms of how social workers viewed and accessed providing care through telebehavioral health. So as I mentioned earlier, we worked with the National Association of Social Workers to find a large group of social workers. We developed a survey, and we tested and piloted the survey with a small group of social workers. And we used the NASW membership pool as a convenient sample of practicing social workers. And the survey was distributed through email to a subset of social workers. The survey was open for about 4 weeks in June of 2020. So pretty quickly after some of these federal kind of emergency policies were put in place. We used a mixed method approach. So it was a survey where most of the responses were closed-ended, but we were curious in doing some open-ended questions. And so we did some qualitative kind of thematic analysis of the open-ended responses. Our sample, again, was social workers. We had a response of 585 participants. Some interesting kind of considerations about our sample was this was an older group of social workers. So these folks were on average 54 years old and had practiced for close to 20 years at their highest degree. 88% were licensed to independently practice, so whether that's LCSW or a licensed independent clinical social worker, and about 65%, so 2/3 of the sample, worked in private practice, which is an interesting kind of consideration that I'll talk to you all about in a second. All right, so let's see. So prior to COVID-19, we asked, did you as the participant provide care using telebehavioral health compared to after COVID-19? And there was obviously a significant jump between these two groups. So we asked both for the respondent about their individual use of telebehavioral health as well as the organization that they work for. The organization is in orange here. And so these are, the pre-rate of telebehavioral health prior to the COVID-19 as compared to after COVID-19, as well as individually. So about 28% of the sample reported that they provided care through telebehavioral health prior to COVID-19, as compared to 92% of the sample reported using telebehavioral health. So almost a threefold difference in using telebehavioral health pre and post kind of COVID-19. And we looked for regional differences in telebehavioral health. There are some kind of considerations in other type of health settings that there were differences. There was no significant differences across the health and human service regions. There was some descriptive differences, but when we looked at these statistically, there was no significant difference. And we asked social workers what kind of behavioral health services they were delivering. The majority were providing individual therapy using telebehavioral health. 2/3 were providing family therapy through telebehavioral health, but only about 1 in 5 reported that they were using some type of a group therapy model using telebehavioral health. And then we asked about training. So as I mentioned earlier, although telebehavioral health is not new, that particularly in the field of social work, training social workers to use tele is not as common as we might hope or we might consider. And we asked social workers prior to COVID-19, did you ever receive training on delivering care through telebehavioral health? And a little over 20% said they had received training prior to COVID. But since COVID, about 50% had sought training, and they sought it from a number of different mechanisms, either through their professional organization like NASW, or through their employer, through the Telehealth Resource Center, through their School of Social Work, through continuing education, and even through local, state, and national governmental agencies who put together trainings. We asked social workers what barriers there were to telebehavioral health since COVID-19. So this isn't prior to COVID-19, but this is since. And so as expected, we didn't see as much of the financial barriers that have been described for telebehavioral health implementation, since reimbursement was an option for them. But what they did note was a significant portion of client-centered barriers. So 73% of the sample reported that there was a client barrier. And specifically, we asked about, was the client interested in engaging in telebehavioral health? Did they lack the knowledge to receive like the technology knowledge, or did they have privacy concerns? And it kind of went across the board of these different client barriers, but the primary concern was certainly a client-centered barrier. We also allowed them to select other and say, is there another type of barrier that impacted, a facilitator, what supported your use? And we coded them into these 7 buckets. I won't go through all the buckets. I'll just highlight a few of the facilitators that the behavioral health social workers reported in open-ended questions. One was just highlighting kind of the state and national policy changes to support telebehavioral health. So when we asked what factors supported your use of telebehavioral health during COVID-19, one person said insurance companies are paying for it. Another person said ability to get reimbursed for phone sessions. So certainly the simple ability to be reimbursed for it and to be reimbursed for tele allowed them to change their practice and to do this. They also described the organizational and employer supports. So this individual wrote, I'm a part of a large private practice that dealt with all of the logistics for us practitioners to have access to telebehavioral health. They researched all the insurance providers to allow telebehavioral health. And this was kind of something that we heard through the open-ended responses, that although many were pleased that CMS was reimbursing for telebehavioral health, there was this kind of concern of the door closing through private insurers paying for telebehavioral health or reimbursing for telebehavioral health. So although they were able to be reimbursed in that moment. And it was almost this feeling that telebehavioral health at any time might go away. And so kind of the unsettling feeling of not knowing when that was gonna go away for private insurers. Other people just wrote kind of having technology supported their use. So thank goodness for Zoom. Some folks were saying, you know, I have a new computer just at home, and so that's why I was able to do it. And some also described just having that private space in their home with good internet supported their teleuse. The necessity to do it was often a consideration. You know, as I mentioned, about 2/3 of these were private practitioners. And there was this kind of understanding that without being reimbursed, these social workers would not be able to provide care and not be able to be paid. And some even talked about that they, you know, paid rent and had paid space, and that if they weren't able to provide care, they wouldn't be able to make their bills. And so in some ways, kind of providing telebehavior or the reimbursement for telebehavioral health kept these small businesses, if you think about private practices as small businesses, in place. This person wrote kind of what factors supported. They wrote, necessity. I am medically compromised myself, and my own PCP has advised me to work from home only for my own health and safety, and I must continue to work to support my family. So kind of at the end of the survey, we said, so what do you all think about it? What do you all think about telebehavioral health? Would you use this in the future if you could provide care in this way? And 84% reported their desire to use telebehavioral health beyond the COVID-19 pandemic. So we were surprised just kind of how the overwhelming kind of positive feelings about providing care in this way. But there was not, you know, there was the positive and the negative views, and then kind of this please advocate pool. But the positive views were really about, you know, that this kind of allowed them to try something that they had been interested in, but just hadn't had the ability to do, and they really do like it and they'd like to continue. Some even wrote things about that it supported clients' access because clients don't have to take the transportation to get there or pay for parking, or instead of canceling an appointment, that they were able to kind of keep that appointment through tele. And then some kind of had more of a negative view that it was difficult to engage the population that they served, particularly for folks who served older adults or who served children, that tele was a more difficult method to provide care. And then certainly there was kind of a group of folks who just said, you know, please, we need this to continue, particularly for audio only. Just highlighting that for some clients, the video was not an option for them due to broadband or just their own the client's technology ability, and that audio only was really how they were able to provide care. So kind of our kind of key kind of takeaways from this, you know, in the ideal world of telebehavioral health being the genie that is out of the bottle that cannot be put back, which is how do we support telebehavioral health moving beyond the pandemic? Certainly continued service parity and reimbursement for telebehavioral health was critical. If you look at the, you know, 30% used it prior and 90% plus used it after, certainly just the ability to be reimbursed significantly changed practice. And unfortunately, we identified that a low proportion of the sample had any training in telebehavioral health, and that's certainly an area for growth. But then finally, as I mentioned, that the client barriers were one of the largest barriers to providing telebehavioral health. And so, you know, certainly we need to train social workers and other behavioral health providers in tele, but certainly supporting clients' use of telebehavioral health. And I'll talk about that in the next slide in terms of health equity, what that might mean. And so kind of, you know, COVID-19 has highlighted, for those who weren't previously aware, of the deep structural inequities that impact folks' health and well-being, particularly for folks who are racial and ethnic marginalized groups. And so kind of the image on the left highlights just the increasing of social needs for folks across racial and ethnic backgrounds, just highlighting that the need is high, and that COVID has only reinforced you know, disparities in need. And that although telebehavioral health has kept a lot of folks accessing care, that we know that there are broadband and other technology issues that keep folks from accessing telebehavioral health or telehealth more broadly. This paper published in the American Journal of Public Health, which just describes, is broadband the next social determinant of health? And so right now, we would be curious to see, if there were disparities across telebehavioral health access and use, if those behavioral health disparities that we see in in-person care carried over, or if there was ability to reach a larger population of vulnerable or marginalized groups through telebehavioral health, would be curious. So I want to end it there, and hopefully we have plenty of time to ask some questions. And I appreciate any of your thoughts and your feedback. Thank you.
Thank you, Brianna. And again, audience, feel free to put questions into the Q&A box. I'll maybe start things off with a couple questions, just to amplify some of the points I imagine that you've made very well here. So Brianna, you reported that less than half of social workers that you surveyed had training in the use of telehealth. And even after the rapid spike in use after the onset of, even after the spike after the onset of the pandemic. And in your discussion, you mentioned the need for more training in telebehavioral health. So when you talk about training, I mean, there's certainly the training to use it functionally. But what do you think the most pressing training needs are in terms of the substance or the changes in providing services via telebehavioral health as opposed to in person? And so what should we be thinking about or inquiring more about to understand how care might be different with telehealth?
Yeah, thank you. No, certainly there's the technology component of it, of providing telebehavioral health. And as I mentioned, 2/3 were private practitioners. So they don't have an MA in their waiting room who's going to sit with the client or call the client ahead of time to make sure the tele visit goes smoothly. So, for many of the social workers, they wrote, they spent some of their visit trying to make sure their client has access to it and could use it. So there is kind of this usability issues, but in terms of kind of thinking about providing quality care, behavioral health care, there is evidence for telebehavioral health, certainly for depression. The VA has extensively tested via telehealth and has found it's been ineffective. But it's unclear, particularly for vulnerable populations or children, if it is as effective a care as in person. And some of the things that we've been hearing, both as part of this that they were hoping for training on, is certainly kind of confidentiality and privacy when you can see into someone's home, as well as how do you screen and conduct risk assessments for someone's home. So when someone's in the office and discloses to you that they might have self-injury or self-harm, or they might be at risk for harming themselves or the others, you know where they are and you know how to take the steps to ensure their safety. If they're zooming into you, you might not have kind of the accurate address where they are, or be able to, send crisis services to them. So there's certainly this kind of concern of both respecting the privacy and confidentiality of clients, but also wanting to make sure that they are appropriately meeting their needs for risk and harm. And those things are kind of unclear of what is, how does the in-person confidentiality and privacy expectations translate to a remote, when you can see into a client's home and you can see paraphernalia, you could see maybe things going on in the background. Where is your line of duty in that space?
So would you say that, I think I'm hearing you say that perhaps we need more research on that, on those different skills needed when we're doing telebehavioral?
Yeah, we're curious, with clients who have access and kind of technology that telebehavioral health can be effective, but is it effective for folks who might have more unique needs, and kind of expanding the research on telebehavioral health for different populations is certainly needed, particularly children and folks with substance use disorders could be helpful to gain clarity on. Yeah.
Well, that's a good segue to my next question. I mean, you mentioned that one of the barriers for some clients is just broadband access. And of course, I think we have the ear of the administration and some others to try and improve that. Are there other specific ways that you know of or have become aware of from the research to avoid reducing access to more vulnerable populations, or kind of the inverse? Are there ways or specific ways that we could amplify here to maybe increase access for vulnerable populations? I'm just trying to hone in and get to some more specifics if you have any.
Yeah, it's so curious because telebehavioral health was really prior to COVID for folks who lived in rural settings who didn't have access to a behavioral health provider, but certainly you had to go to a site that was approved to be able to be reimbursed. And so in some ways, what telebehavioral health was really developed for, which is to reaching hard to reach populations. Those are likely the populations that don't have broadband or connectivity. And so in some ways, it's a kind of like a curious gap. I am hopeful that, certainly COVID has highlighted kind of the need of broadband, but I think the research needs to kind of come forward of whether different populations want to be on video, and if there is any kind of like stigma or privacy concerns on the client's end, where audio only is a way to reach different groups of folks. And so I think that will be interesting kind of in the next 6 to 12 months to really hear more about the client's perspective of access. I think a report just came out yesterday that 1 in 4 Medicare beneficiaries access telehealth during the last year. So I am hopeful that as more people access telehealth, that kind of the concern of privacy or kind of the fear of what this is can decrease. But we don't know if all folks want to access care in this way in order to reach the populations that I think we are hoping to reach through tele.
So looking at the provider side of things, then if insurance, let's assume insurance payment does continue for telebehavioral health at the current levels, or for maybe even more services, what effect do you think that would have on the availability of the behavioral health counselor workforce? For example, do you think it could help or hinder high turnover in safety net sites? Or what about interstate compacts? If allowed, might social workers be inclined to work across state lines?
Yeah, this is such a really kind of fascinating thing to think about where we could really go. So much of the workforce literature is that we have providers, they're just not in the places where people are needed. And certainly in some aspects, tele could help us redistribute providers into different areas and communities. But that opens, a number of concerns. One is interstate compacts. Social work does not have anything like that, although the NASW just received a grant from the DoD to really study interstate compacts and see if this is something that we could look towards in the future. But there's also some concerns about, although I heard a really great story about a federally qualified health center kind of zooming in their behavioral health provider, was able to provide services in the native language of the clients, and that they couldn't recruit someone to their region, but they were able to provide care by zooming someone in. So there is some really kind of benefits to that. But then I heard some concerns that if the provider doesn't live in the area, they don't really know the services in the area to really support clients in accessing not just behavioral health supports, like psychiatry or other types of behavioral health supports, but like social needs. So they wouldn't know how to refer them to the domestic violence shelter in the area. They might not know the crisis support centers in the area. So although it could redistribute folks in ways that more people could access care, it might have some limitations. And then certainly we know that tele needs a face behind it. So although we could redistribute folks, we still have to think about kind of our total number of providers. And every single behavioral health provider I have talked to has said they are overwhelmingly full. They have got, they are not in need of clients, that people are accessing care, and almost that feeling of guilt that they can't provide more care to folks. So it will be curious to see kind of how that goes, particularly with the interstate compacts. Could be really interesting.
I'm seeing a couple comments coming in or questions. I think one is just kind of echoing what you just said, that a concern for social workers practicing outside of their area is that they wouldn't know the resources. I think
Exactly.
on that. And then referencing back to my first question, I think what kinds of training and capacity building could providers benefit from to better provide services using telehealth? I think there's a misconception that telehealth is only about equipment, and I think that's similar to the question I was asking.
Yeah, I think, I do, which is what we I've heard it a little bit through research that have asked clients about their tele experiences, and certainly in the study that we did is, the equipment is the scary first part, right? But once we get over that hurdle, there are certainly a lot of other kind of training needs that we need to consider. I mentioned a few regarding different populations might have different unique needs. How do we respect privacy and confidentiality? How do we make sure we're referring to services or know the resources in areas that we aren't physically in? And kind of a last one that I'll just kind of put a thought out there is some folks were saying, COVID has brought an onset of grief, of trauma, of difficulty, that we need training on COVID-related grief, COVID-related difficulties. And certainly thinking about this is kind of a new type of experience that we're all going through, and how providers should care for those folks moving forward.
Well, great. And David, I believe we're at time, but I just want to take a moment to thank you, Brianna, for this great presentation. And I thank the Health Workforce Technical Assistance Center for giving me the opportunity to be involved. Anything else, David?
No, not really, except thank you too, Sue. I mean, we really appreciate you, agreeing to moderate this, what was really a wonderful presentation. Thank you, Brianna. I thought it went really well today.
Thank you. Thank you for having, and yes, thank you, Sue, for the questions.
Yeah, wonderful. Wonderful. And for those of you in the audience, by all means, thank you for attending. And of course, we hope to see you again in the future. I hope everyone has a good afternoon.
Thank you.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.